Hello, welcome back again for another exciting episode with the NailedIt Ortho podcast team. We have another great one in store for you today. Again, my name is Dr. Jay Fitz, and my partner in crime here is
Dr. Wendell Cole. Some people know me as Cody, but most people say Dr. Wendell Cole, you know?
He's a complicated guy. He has a lot of names. So, guys, I think this is a good one. This is a very high yield subject. It's something that you'll see pretty often if you ever go to a spine clinic. So for residents, for med students, attendings, I think this is a great one for you. I'm gonna let Cody get this show going for us.
Oh yeah. No, this is actually a really good episode. We talk about cervical myelopathy. We actually have one of our good guests, actually Dr. Matthew Cyriac, who happens to be one of my attendings at my residency program, one of our spine surgeons. He did a really good job talking about cervical myelopathy, explaining it in a very proficient manner. He did a very good job. Just kind of a little bit more about him. He actually got his med school degree from Albany Medical College of Georgia. He did his surgery at George Washington University Hospital. He did his orthopedic surgery residency there. And then he did his spine fellowship actually at Emory University in Atlanta. He also holds an M.B.A. as well. So he's an M.D. as well as he has his master's in business. And, guys, without further ado, enjoy this conversation on cervical myelopathy.
You are now listening to Nailed It, the Orthopedic Surgery Podcast, featuring Doctors Jay Fitz and Wendell Cole.
Welcome to the show.
Thank you. Thank you for having me.
So the first question we actually have is, you recently finished fellowship, not too long ago, and, now you're living the attending life. And we kind of just want to know, like, to you right now, what's the best part of being an attending?
Well, you have a lot of autonomy. You get to make the decisions, and you train really hard to get there, and you make the decisions and you help people. So it's kind of nice finally you have the autonomy and you've spent years training. And then the surgery, you're doing the surgery and you're helping people. So the autonomy. And then second is, you have your own call schedule in terms of time. It's great.
Okay. And on the flip side of that, what would you say are some of the unexpected things that you're starting to notice now as now that you're, attending versus when you were a fellow?
I think the first 2 years, I'll be 2 years out now, but the first year is very stressful in the sense of your board collection, and then complications, especially in spine, is high risk. So some of the complications are devastating. So you quickly realize that maybe, that you're responsible for a lot of that, and stuff can go wrong very quickly. So something very stressful, but then you get used to it.
Yeah, what's the curve on that? It was about 5 months of stress, or it was about a whole year of stress, and then you kind of got used to it?
No, it's really a whole year, maybe a little bit more. It's really the board collection period that's stressful. Right. Anything that happens, it's all documented, and it's a stressful. I think it's a year and a half, and then you just get used to it all.
Right. And then, a third question is, what made you choose spine out of, all the orthopedic specialties out there? What made you go into spine? Like, is this something you went into residency knowing you wanted to do, or did you just take spine call and loved it? Like, what made you spine?
I think, it was, I actually went into residency. I think I wanted to do sports medicine, but I changed, I think, my third year, actually, because I was on a spine rotation. It was such a good rotation where I did residency in DC at GW that two of my mentors were a great influence. And so, if you have good mentors who like what they do and how they do it, you become interested in it.
Okay. All right. Well, good deal. I think we're going to go ahead and jump into the case. Oh, yeah. On the case here, so we have a 56-year-old male who presents to your clinic complaining of problems with balance, not being able to button his shirt, and just saying that he's had some progressive neck pain over the past 5 years. From this point, how would you approach this patient at this point?
Yeah, so typically when someone presents with, if you're talking about cervical myelopathy, that's a clinical syndrome of someone presenting with symptoms of really often the first symptoms that you see in cervical myelopathy is someone, they really, 56 is relatively young for myelopathy. That's someone who probably has congenital stenosis, meaning that they were born with a smaller canal. So they're having to start these symptoms earlier. Typically, cervical myelopathy is usually seen for me in 60 and sometimes often 70. So 50s and 40s are relatively young, but 56, I guess it's in the middle too. But basically, so when someone complains of, and they never, it's very vague. They just think they're getting older, that they're dropping stuff, and their hand dexterity, such as buttoning stuff, is decreasing to me. The first thing I think of, is there any cord compression going on that's causing this? So I typically, first start with further questioning of, is there any problems with their balance, especially going up and down stairs? Do they have to hold on to the rails more if they close their eyes? Like in the shower, do they feel like they're going to fall? And then, and then the exam, for me, the first thing I look for is a Hoffman sign, which I guess we'll go over later. And then I order an X-ray. An X-ray typically will show some spondylosis, which is basically degenerative changes, disc degeneration, some anterior spurs, and, the facets are degenerative. And then you have to get an MRI to really see if there's any cord compression. And from there, if it's very mild, like this person, you can describe the natural history of cervical myelopathy, and then kind of watch it. Or if it's more severe, then you can tell them, look, I wouldn't wait too long on this, but we should probably think about surgery at some point.
Right. So let's rewind. So for those listening that may not know, what is cervical myelopathy, and kind of like how does it progress? Like how does it?
Cervical myelopathy just means, so there's a lot of causes of, if you look at cervical myelopathy. Myelopathy it's a clinical syndrome that presents due to cord compression, basically upper motor and lower motor neuron long track signs such as, balance, hand dexterity, hyperreflexia due to, compression of those long tracks or the cord. And that's basically cervical myelopathy. There are a lot of causes of it. The most common cause, which we're, often see, is cervical spondylotic myelopathy. That just means myelopathy due to spondylosis, which is degenerative changes. Other causes of cervical myelopathy, you can get epidural abscess, you can get a tumor. I see it, in trauma call when, someone, a car accident and cervical fracture, facet fracture dislocations, they compress the cord. That's myelopathy. The most common, what you're going to see is cervical spondylotic myelopathy, or CSM, which is due to the degenerative changes, and that's the most common cause.
Okay. And yeah, so and on that same picture, so it's so many different, like you say, so many different causes. And that's why I was really looking forward to this talk, to see kind of how you go about approaching trying to get to the bottom of that. And not even that it's so many different causes, but it just presents in so many different ways. I guess, what are some of the more subtle signs? I know you said sometimes like hand clumsiness, and I'm guessing you're looking for maybe some neck pain. Is there anything else to kind of look out for when that patient first comes in that should kind of key you in, like, okay, this is something I need to rule out?
Yeah, it's usually that they complain of dropping objects as the number one. They don't know why, but the cup falls out of their hand. Their handwriting can change. Cell phone drops out. Buttoning their shirt. Pulling up the zipper. It's just, for some reason, it just feels clumsy, right? They can't really put a word. It's kind of vague. And then that's the first sign. And then you can, as you progress, you can get gait instability, which, they just feel unsteady. They don't know, especially going up and down stairs and starting to hold on to the rail more. All the other stuff like urinary retention and all, that's like very, very late, very severe cord compression. It's really the hand dexterity and the clumsiness, and then the gait instability is the first things I look for. And, right. That's when you start looking for cervical myelopathy. I mean, the differential diagnosis is, most common is that degenerative thing, but then they have severe pain or IV drug user, you think about epidural abscesses, but those are typically presenting to the ER, right? The trauma stuff presents to the ER, which you're seeing in clinic is a different setting, and that's usually the degenerative, the slow thing that you see over time. And that's what you're seeing in clinic typically. And then if there's a younger patient that I have seen a couple of times present like multiple sclerosis, right? That's a demyelinating disease. They present with, problems, sometimes dropping stuff, gait and all that stuff. But that's in a younger population, typically a female, 30s, sometimes 40s, that presents with vague symptoms of being off balance. People think they're drunk. But that's more rare, right? And cervical spondylotic myelopathy is more common than MS.
Right. And so like when you've gotten the history, so when we're doing the physical exam, what are some of the like important things that we want to do, the important tests that we want to check off, or like what are
the first thing, is a motor strength exam. And a quick comment about neck pain. A lot of these patients older with cervical myelopathy often don't have neck pain. I mean, that is there. Almost everyone has some neck pain, but oftentimes that's not their main complaint. Now, if they have at the same time radiculopathy, which is different than myelopathy, radiculopathy is when you have nerve root compression, not the actual spinal cord, and with presence of radiculitis, meaning that pain shooting down the arm in a dermatomal pattern, and also, that's that radiculopathy associated with a specific myotomal weakness, like a C4-5, disc herniation resulting in, on the left side of cervical radiculopathy. They can have what you call, this is more technical, myeloradiculopathy, the myelopathic symptoms, which are the cord compression symptoms, such as, the diffuse hand numbness, non-dermatomal pattern numbness, and then also some radiculopathy, maybe some shooting pain. And then neck pain too, you can get it because neck pain, if you have arthritis, cervical spondylosis, you can get neck pain. But some of my patients with the myelopathy don't have neck pain is not their number one complaint, which is interesting. But some of them it is. So that's kind of the history compared to, your typical lumbar stenosis where they present with pain as the main complaint, where sometimes myelopathy patients present with that, the vague symptoms of diffuse hand numbness, non-dermatomal, dropping stuff. Then you get to the exam, and for me, classic exam starts with I start with the motor exam, and you grade it in terms of, for me, C5 to T1 myotomes, basically deltoid, biceps, triceps, wrist flexion, extension, grip, and interossei. And the first thing for me to go out on that is actually the interossei and the grip. The upper ones, the deltoid and the biceps, they're pretty strong, and you don't see a true deficit of it. It's very, very severe. Right. I recently had a lady that was 83, fell, had, dinged up the cord and presented in a wheelchair with weakness upper and lower extremity. But typically the ones that walk in the office just have that slight weakness in the grip. And you ask them to squeeze hard as you can. If you can pull your fingers out, that means that to me is a 4, which means, it's a subjective grading scale. And then the interossei is the other one. You ask them to abduct their fingers as much as possible. So that's that. And then you look for the Hoffmans. If you look at the studies, Hoffmans is seen about in 60 or 70% of patients with myelopathy. And basically the way you do it is you have them IOPS, and it's hard for them to get them to relax. So I told them to just put their hand on the lap and relax. And you take the middle finger and you flick the distal phalanx just with your thumb. And if you see the index or thumb flex, just flicker, that means that's a Hoffman sign. That just means that when there's a spinal cord compression, that reflex arc is not being regulated by the upper motor neuron due to the cord compression, so that you get that. That's that. And then I also look for the inverted brachioradialis reflex. You tap the brachioradialis, and what it usually does is you get a slight, wrist, the brachioradialis works, and you get a slight wrist like flexion. But inverted is when you have the thumb and the index finger flex. So that's the inverted brachioradialis. And then hyperreflexia, again, due to loss of upper motor neuron control. That you tap the biceps, the most common, and you get a +3, it really jumps. And then you get patellar hyperreflexia. And then you can go to the next ones. I don't often test these as much as Babinski. You stroke the lateral aspect of the foot, and then the great toe extends instead of normally we should flex it. And then oftentimes, if they have a little bit of gait and we're not sure, I have them do tandem walk or toe to heel walk, where they ask them to walk like, the police make them do with one foot in front of the other, and often they can't do it. That's the first time they notice that they have this gait instability. And you can do a Romberg test. I often don't do it, but that's just when you have them stand with their arms fell forward, and you ask them to close their eyes and they start falling over. That's due to the fact that cord compression, you lose proprioception from your feet. And when you have your eyes open, you compensate, but as soon as you close the eyes, you lose that. So these patients, if they have the optical plane in the shower, that when they close your eyes, they get real like about to fall over. So that's what that is. And then, you can do, if there's radiculopathy, you can do a Sperling's test where you, extend the neck and turn towards that side and turn. And basically you're pinching the nerve in that foramen, and they get that shooting arm pain down the side. But that's the patient with that cervical myeloradiculopathy, the radiculopathy symptoms. So that's basically it for the exam. Really, it's the Hoffman's the number one thing I look for. And then grading of the motor strength, and then, reflexia and grip.
Yeah, I think that was like a super comprehensive, great physical exam talk right there. Like I remember I was even doing some questions on it, and pretty much all those big things that you said were all like in the stem of the question. To say, +3 reflexes, positive Hoffman's, and maybe like, proprioception issues. So I think that was a great overview of physical exams.
Absolutely. And that the shower part that you added in, I actually think I had a patient who mentioned that. And I wonder now, I'm like, should I have been thinking so?
Yeah. Yeah. Well, the issue with this stuff is, right, when you get older, people equate everything to age and balance issues. I think it could be a lot of causal balance issues, right? I see a lot of patients present, I get referred over from other people, but it could be due to vertigo. It could be a vestibular problem, or something else. Sometimes they're just, a lot of other issues. But basically, from our standpoint, you do our exam. And for me, the next step is I look for, sometimes the balance issues could be from the cerebellum or higher up, right? Ataxia, but that's a more serious tumor in the cerebellum or herniation, that kind of stuff, Chiari malformation stuff. But those are more rare. That's typically in the realm of neurosurgery, but I still see a lot of that stuff. And if I do see it, if there's nothing on cervical MRI and I'm concerned, I will get a brain MRI. They had that, other symptoms. But typically, for me, the next step after the X-ray is to get an MRI. And from a spine surgeon standpoint, your goal is to rule out what you can treat or help with, and that's cervical cord compression or the myelopathy. So you get that cervical MRI to make sure there's nothing there. And if they have significant gait problems in this, and they have hyperreflexia, you could start talking about thoracic myelopathy, but we'll leave that alone. That's very rare.
Okay. And so we kind of talked about it. I know we mentioned it earlier. So just take a step back on the X-rays. What X-rays are you getting exactly, and kind of what are you looking for?
I only get cervical, AP, and lateral. I mean, AP, honestly, if you're looking, I just look for overall alignment. If it looks okay, make sure they're not coronally imbalanced with the head tilted towards one side, that kind of stuff. And really, it's the lateral. I look at their overall alignment, right? I look at it, make sure they're not in significant kyphosis, because that determines, your surgical planning if they're in a lot of kyphosis. You want to, you can do the C2 to C7 angle to make sure they're in, normal lordosis, which in, most patients can vary, but it can be between, as you age, the lordosis decreases, but typically if you're 50, it should be between, 20 and 30 degrees. But a lot of patients after 50, 60 are just neutral, which is fine. But that's what I look for on the X-ray. When you see the spondylotic changes, which spondylosis just means degeneration. So you'll see those bone spurs anteriorly, the disc degeneration, and almost everyone you X-ray them after age 50 or 60, after 60 especially, will have some of those mild disc degeneration and anterior osteophytes. That doesn't mean you need to rush into and say that there's cord compression there, but those are bony degenerative changes. And then really it's the alignment that I look for. And then, so that's what I do for an X-ray. And then the next step for me, the most important, is to get an MRI. And the MRI really shows you, the cord compression, nerve root compression. And basically you look for, if there is cord compression, you look for that. Everyone looks for myelomalacia. What is it? It's basically a radiological term just saying there's T2 hyperintensity or brightness. That just means that the cord's being compressed and there's that signal change in the axons. And that's what that is. And you'll see that area that's the most tightest.
Okay. And also because I was doing some reading, is there any, I guess, measurements that you do trying to find out about the size of the canal? I saw that, some researchers shown different, if it's less than a certain number, then you have to worry more about stenosis and different things like that. Is there anything like that that you kind of take into play with this type of issue as well?
Yeah, I mean, for me, I don't really use any ratios, but if you ask a lot of radiologists, in a patient without congenital stenosis, once they get to less than 7 millimeters measured in the A to P, you see a lot of radiologists will document. This is different. Spinal surgeons in general, I don't often go by the numbers. I look at it and I look for that cord compression, and I don't write a number, but radiologists write a number. But to them, if you ask many of them, it's less than 7 millimeters means that there's, significant cord compression. So they write that number in there. A normal spinal canal typically is like 17 millimeters. So once you get to that 7, that's considered, for a lot of them, considered to be, pretty tight, pretty significant stenosis.
Right.
So only time I get CTs is sometimes for surgical planning. Really, if I'm doing, a posterior fusion or laminoplasty, I just want to look at the lateral masses, calculate how long my screws are, that kind of stuff. And then if I'm doing like if I'm doing an anterior approach, you worry about, this is more technical, ossified posterior ligamentum, OPLLO. That just means that can calcify, and an anterior approach can be get you in trouble because you can get a dural tear very quickly. So this is just to rule that out. If you see that big kind of black line on the MRI anteriorly, you worry about OPLL, then you get the CT scan. But I have been getting CT scans more often just for surgical planning, but that's not really, required. You can go with the MRI. And then, if they can't tolerate an MRI, I have had a bunch of patients with pacemakers or had a spinal cord stimulator and put somewhere else, and they need a CT myelogram, which is basically, they inject a dye into the epidural space and then have them lay in the CT scanner and Trendelenburg and have it float up, and then to get a CT scan to see the dye and look for cord compression. That was done a long time ago in the past. Not a long time ago, but a lot of people did that. But often I don't do that as much unless they have a contraindication, such as a pacemaker, or they've had a lot of previous neck surgery and there's too much hardware artifact. That a CT myelogram is very useful.
Right. Now, when you're looking at these, when you're looking at these films, whether MRI, whatever, or the different imaging, is there any way that you are able to tell, or are there any clues that you can tell whether or not, hey, this is something that's probably just a congenitally narrow canal versus, this is probably something that has to do with some spondylosis?
Yeah. So, classically they talked about, the Pavlov Torloff ratio. I just honestly kind of look at it, and you can tell I guess this is a bad way to explain it. You can tell by looking at it that, it's just narrow diffusely all the way from like C2 to C7 compared to what you've seen before, but the actual ratio is 0.8, meaning that if you take a ratio of the vertebral body to the anterior posterior canal diameter, if it's less than 0.8, that means that they have congenital stenosis. And that's the Pavlov ratio. So basically you measure anterior posterior on the lateral X-ray. It's basically what the original study described it as, anterior to posterior on the vertebral body, and then you do anterior posterior in the canal from the posterior vertebral body to the back to the spinal laminar line, and you divide the diameter of the canal by the diameter AP of the vertebral body. If it's less than 0.8, that means that they're congenitally stenotic. But oftentimes I look at the MRI and I guess this is a bad way to ask most surgeons, ask them trying to define congenital stenosis. A lot of times it's just looking at it and you've seen enough of it and you can kind of define, that the CSF space is just so small around that cord, on that T2 sagittal.
Right. Okay. And so I guess transitioning into now the treatment options, in what patients are you going for non-operative treatment? I guess first off, and then we'll go ahead and go on operative after that. But what are some of the non-operative indications and treatments?
So if you look at how you grade it, I think it's one of the previous old ortho bullets questions. We don't use it as much as a Neuric scale. And I basically looked at the patient's ambulatory status. If they were grade 4, which is very severe, that was wheelchair bound. By the time you get to that, that's trouble, right? If you just look at gait, because that's one of the final things if they're in a wheelchair. And then the Japanese came out with the Japanese Orthopaedic Association scale for cervical spondylotic myelopathy. And basically what they did was like the hand dexterity, upper extremity function rather than just ambulation or lower extremity function. And they found, they initially came out with it with chopstick use. If they can use the chopsticks well, that means it's normal. But then in America, Benzel modified it, and this is the most common use of the modified Japanese Orthopaedic Association scale to look at, the upper extremity dexterity. So instead of chopsticks, use of spoon, able to button your shirt, and that's really it. So it's based on that, and that's how in research people grade spondylotic myelopathy with a modified Japanese scale. And, the higher the score, the better. The lower the score, the worse. But if it's mild, that means, they have a little bit of hand numbness in the fingertips and dropping stuff here and there. You look at the MRI and the cord compression is, there's a little bit of cord compression, no myelomylation, meaning no T2 changes. Then you can just, in those, I tell them, hey, look, you got a little bit of cord compression. You have some early signs of cervical myelopathy. I'm going to watch you, either see you every year and just kind of watch you, and non-operative management in terms of physical therapy and stuff. I tell them not to do any extensive neck hyperextension and therapy and stuff, but just basically gait training and maybe upper extremity strengthening, cervical isometrics without any traction, that kind of stuff. And then if they get, a little bit of neck pain or radiculopathy, you can use NSAIDs, that kind of stuff. And you see them every 12 months and tell them what symptoms to watch for, really. That's why I tell them, look, if you're starting to drop stuff more, if your, balance is getting off. And I tell them to avoid high-risk activities such as, skiing, that kind of stuff. They fall the wrong way, they hyperextend their neck, they can get paralyzed. But driving, all the normal stuff's all fine. And people always ask, am I at a higher risk for being paralyzed? Yes, you're slightly higher risk than me, depending on how much tight the canal is. But in general, you should be able to do most activities, except for skiing is higher risk activities. So I see some younger patients with this cervical stenosis or a little bit of tightness. They say, "Oh, can I stop doing everything?" I'm like, well, you're a slightly higher risk. It doesn't mean you should stop everything, but maybe like extreme mountain biking, that kind of stuff. And basically just watch. I don't use a collar or anything for this. Some of the studies recommended collar. So they don't hyperextend like a soft collar, but I don't know many people that do that. Basically, just see them every year and kind of watch their progression of myelopathic symptoms and tell them the natural history of cervical myelopathy, the fact that they do fine for a while with no change in symptoms, et cetera. And then they suddenly, have a sudden change in symptoms. All of a sudden they're fine for 1 year, 5 years. And all of a sudden they notice, I don't know, doc, I'm dropping stuff more, my balance changed. So it's a stepwise rather than a continual gradual decline. It's a stepwise, meaning they're fine for a while and sudden drop in function. And then they're fine for at that level for a while and sudden drop. And that's based on older studies.
Oh, I was just going to agree. Yes, sir. I was seeing that same thing in some of the studies that we read to kind of prep for this case. Is like you're saying, it tends to progress over time, and like you say, kind of have sudden drops and just kind of go back and forth that way. But
that's basically it. You just kind of watch it. Everyone's concerned, right? They see this MRI, the radiologist has read it as cord compression. What do I do? Am I going to be paralyzed? And you just kind of tell the natural history, be careful, but try to live your life, and then see me in a year and we'll keep track of it. If there is enough cervical myelopathic symptoms, I said, look, I don't know when, but at some point you may need surgery because that's the only way to prevent further progression.
All right. And on to that, that's what I was going to say next. So how do you choose, what, as far as what surgery you're going to do, what approach you're going to take, and, just overall, how are the outcomes normally in the best case scenario?
Yeah. So typically, if it's 1, 2, or 3 level, I will do an anterior approach unless they have OPLL, ossified posterior ligamentum. In that sense, the ossified posterior longitudinal ligament. In that case, I don't go anterior because as soon as you burr through that ossified ligamentum, you go right on a dura and you get a CSF leak, and those are hard to repair anteriorly. So typically 1 or 2 levels. 1 to 3 levels, I'll do anterior, just because the recovery besides for dysphagia is quick. I can do just a single transverse neck incision and take care of most of it. So the questions on the OIT are typically, when do you do anterior versus posterior? Well, basically, if it's 1 to 3 levels of compression on the test, they're going to give you pretty more simpler stuff. They'll give you 1 to 2 levels with, with the cervical spondylosis, with the bone spurs that are touching the cord. Those 2 levels, most likely you need an anterior approach, ACDF. If there's stuff that's jutting behind the body, retrovertebral body disease, I don't know if they ask you this, that's one of the indications for doing a corpectomy. But if they have a lot more, then they're not going to give you the 3 level, right? Because 3 level, you can go anterior or posterior. But once you get to 4 levels, posterior works better. You can either do laminectomy and fusion or laminoplasty. And, I do a lot of laminoplasties. But basically what determines if you can do a posterior versus anterior posterior when there's, 4 levels of compression is the kyphosis. If you have less than 10 degrees of rigid kyphosis, then you can do posterior. And the way I determine it is I do the modified K2 line. Basically, I draw a line from C2, the center, on the MRI, originally described in the X-ray, but I just do it on the MRI. You can do it on X-ray too. To the center of the canal at C7. If that line is not touching any back of any of the posterior vertebral bodies, that means that the way posterior decompression works is you're allowing the cord to drift back. Mm-hmm. So if it's less than 10 degrees of rigid cervical kyphosis, then you can do posterior for, typically on the test is 4 levels or more. And they're not going to make you choose between a cervical laminectomy and fusion versus laminoplasty on the test. They're really making you decide between anterior, posterior, and that really is determined by how much, if there's a lot of kyphosis greater than 10 degrees, then you have to go anterior. And let's say it's a lot of kyphosis and multiple levels, then you have to go anterior and posterior rather than just anterior. So it's 1 to 2 levels, and they have a little bit of kyphosis, or they're normal on 1 or 2 levels. They're going to, the answers are in ACDF on the test. But if they have, usually they're going to give you 4 levels and somewhat neutral alignment or not kyphotic, then you can do posterior either. They're not going to make you choose, but typically laminectomy and fusion or laminoplasty, but basically something posterior. And most people do laminectomy and fusion. Laminoplasty is done much more in Japan, but I do quite a bit of laminoplasties.
And what are the advantages for some of the different like anterior approaches, like the advantage and disadvantage of each, like, range of motion and different things like that?
Well, the main advantage for me, anterior is such a smooth procedure, and the recovery for me compared to a posterior laminectomy and fusion, they have a lot less pain. To me, in my hands, a lot less blood loss, lower infection rate, and decreased in my hands. But the newer studies show that it's equal C5 palsy rate. So I love anterior if I can do it. But the biggest downside is the dysphagia, meaning you have to be careful with the exposure. And a lot of patients, I tell them, you're going to have a sore throat for 2 weeks and a lump in your throat, that kind of feeling for up to 6 weeks. Most say dysphagia, if you look at the studies, resolves by, 3 months. But that's the biggest factor. So in some of these elderly people who already have a lot of dysphagia or someone else, maybe going in the back may be the better choice. But I often, 1, 2 level disease, and even up to 3, for me, I do an anterior approach. And posterior, you're cutting through all that posterior neck musculature and then dissecting. They hurt, and the recovery is a little bit longer. But the advantage is that you don't have dysphagia, and you can take care of multiple levels with it, right? In ACDF, I typically don't do more than 3 levels, but you can do 4, 5, 6, 7 levels with a, laminectomy and posterior fusion or just a laminoplasty. It works well. And so that's it. And then the studies show that anterior and posterior are equal in terms of C5 palsy, but some of the older studies all show that posterior approach always had a higher rate of C5 palsy, which is basically you wake up with this deltoid weakness, meaning that it's usually unilateral. After surgery, it takes up to 72 hours for it to develop. They wake up and they can't really abduct their shoulder. That deltoid's weak and they're like, what's going on? So that's what that is. And the older studies showed that, it's a higher risk. And then anterior, people, the dreaded recurrent laryngeal nerve injury from an anterior approach, they present with hoarseness and et cetera. So, but that's usually seen when you're at the lower levels, especially at 7-1, sometimes 6-7. And that's why typically these people always used to go on the left side, but the newer studies show that there's no difference between going a right-sided or left-sided anterior cervical approach in terms of risk of recurrent laryngeal nerve injury or, the palsy resulting in hoarseness and sometimes some dysphagia.
All right. Well, I think that was pretty good. I think that was really good. So I don't know. I'm gonna ask a question we usually don't ask, but I think it's helpful. What is something some of your residents or some of your newer residents or some of your colleagues maybe that you just feel like some people kind of either forget or overlook when it comes to this type of pathology?
Well, I think spine, especially in orthopedics, it's sometimes you don't understand it. Where compared to our neurosurgery colleagues, they get experience in that by year 1 or 2, right? For us, it's more the senior residents or higher up when you see it. When I was a first, second year, I dreaded the spine stuff. But once you get the understanding of it, it's kind of simple. Basically, cervical myelopathy to me is people are like, what is that? It's an interesting term. all it means is cord compression. Basically, you just look for the basics, the hand dexterity, the dropping objects. Just watch out for that. The gait instability. It's not just due to old age. It's maybe due to that. It's easily treatable nowadays with modern, surgeries. You can do it well and efficiently. So that's the thing to watch out for, and one of the newer studies actually show that patients with hip fractures, 20% actually have cervical spondylotic myelopathy, and that may be the reason why they fell and then sustained that hip fracture, and the reason for why they're post-op, they're using the walker and the balance issues. That was one of the studies in Spine recently. So it's interesting. So it's there. So you want to watch out for that, and basically, look for the Hoffmans and the decreased grip and maybe the hand dexterity, and it's easy to pick up. And are there a lot of people that have those symptoms and don't have any cord compression? Yes, but it's pretty easy to diagnose. You get an MRI and you see the cord compression. I think it's relatively simple.
Okay. Well, perfect, Dr. Cyriac. Before we go, I would like to ask you, for our listeners, is there any way that our listeners can reach out to you, whether it may be some of your social media handles or your email address or anything like that, where people can?
Just email me with questions. mcyriac@tulane.edu. That's mcyriac@tulane.edu. Yeah, feel free to ask questions.
Thank you all for listening to yet another episode of the NailedIt Ortho podcast with Dr. Cyriac. I hope you guys really enjoyed this episode and learned a lot. I know I definitely do it, and especially listening to this again, I know I jotted down some more notes. So guys, don't forget to subscribe, go and rate us in iTunes, and follow us at NailedIt Ortho at Instagram. And if you have any questions, you can also email us at nailedItOrtho@gmail.com. And until next time.